All right, well, happy Doctors Week. Yay. So I hope everyone's had the opportunity to kind of participate in whether it's food, meditation, yoga, some of the activities this week. There's still more coming up tomorrow and Friday, but definitely excited about kind of grand rounds today, and this is a John Calkerham lectureship, and I'll talk a little bit about him in a moment. But then the other big event, please, and those who maybe came late and didn't get lunch because we had huge crowds, tonight, please come to our social at Busboy and Poets, just down the street. It's walkable. If the weather cooperates and you want to walk or run, there's a shuttle where our parking garage is at Brooklyn. You can take that and get over, or you can drive, and there's plenty of parking. But all doctors, MDs, CEOs, PhDs, welcome to come out and join us. And it's just a great chance to kind of just get to know people that you don't know, because definitely even as a medical staff, we've grown so significantly that there's always new people to meet. And it's been great of people just interacting and just getting to know face-to-face instead of, you know, who's someone I'm just talking on the phone. But moving on for Doctor's Day, this Doctor's Day lectureship, now for the last about 8-9 years, has been in honor of John Calkerham. And for those that don't know him, John was actually a cardiologist here. He was one of our first clinical informatics when we actually started down this EHR, and if only we had him now, I think he'd be a great resource. But he also was a president of medical staff. And what was so special about John, again, is what we try to do this whole week, is just his love and his dedication to the medical staff. He thought it was such a great honor to be in this role, and really spent time doing not the nice things, like this is kind of the fun things, I can have lunches and stuff like that, but, you know, the nitty-gritty of, you know, things like bylaws that, you know, will put you to sleep, but, you know, really trying to make sure that those had all the protections and the support that we need to function and function well as a medical staff, and also help us with a lot of the regulation things that we need to do, so we end up being appreciated as the top children's hospital that we are. And so he just was just so impactful that we definitely want to remember him with this. Unfortunately, I think this is the, you know, the second year that I've got to present that we also need to remember one of our wonderful colleagues that have passed this past year. Dr. Jeff Hanway was one of our orthopedic surgeons. He was the chief surgical officer out at PSV. And I think, so sad, but he almost epitomized kind of where we want to go this week, and I think with our Grand Round lectures, of someone who loved the people that he worked with, he loved his life, he loved his job, and he just really shared the joy no matter what he did. And I think even more so that we try to kind of think about right now is just the work-life balance, that he worked super hard and did stuff, but, you know, he also had, you know, spent so much time with his family, he made the games for his kids, coached teams, involved in his church, you know, did a lot of things that he loved to do, and he was able to master that. You know, I don't know how, because I know we all struggle with that, but really he just represents kind of the joy of what we all want to accomplish. And so I think, you know, too, is these are great examples as we kind of think through and reflect, you know, what can we do, one, to love each other here more so that, you know, we appreciate everyone and the work that we do, which makes it a better job for us and helps us take care of our patients, and then also being mindful of, you know, what we do for ourselves and what happens outside this job that keeps us whole. So definitely want to acknowledge him as well. Lastly, as we kind of move forward, I just want to introduce, you know, Dr. Christy Corbeau and Hermant Sharma. I don't think they realized what I asked them to do when I invited them to be chairs of the Provider Wellness Committee, and nor did we expect such a ringing endorsement from Dr. Newman this past fall when he went through provider engagement and really gave the reins to them to say, hey, help us make it better. But they have done an amazing job. And I think, you know, the people that have joined as the Wellness Committee, there is a large group of people from all different walks of life, whether they're physicians or non-physicians who have been a part of this, have had such great energy. So this whole week is due to all their excitement and their ideas, and there was so much more that we couldn't include that we hope to be do in future years. But I'm pleased and honored that there are guest speakers for Doctor's Day this week, and Drs. Corbeau and Sharma.
Wow, thank you. Thank you. We thank you so much for coming. We know this grand round is so important to all of us, and we certainly feel privileged and honored to present our efforts on everyone's efforts on behalf of ourselves, our staff, in remembrance of those doctors that we've talked about today who've really set the tone for us moving forward. So this is the big committee that Karen alluded to. We're large, but we're varied. And it's really important to notice that, one, if your name's not up there, come and call Heyman and myself. We're glad to put you up there. But it does speak to the wide breadth and depth of the interest in the Wellness Committee. It touches upon subspecialists, inpatient physicians, outpatient physicians, and those other individuals who support us in our everyday caring of our patients. And you can read today's goals. I hope we achieve them in the amount of time we have. We've got a lot to cover, but please, if anything comes up and you really need to talk about it as we're discussing it, please feel free to raise your hands and we can stop. We don't want to be talking at you. We want to be talking with you, and we welcome your comments as we move forward. So to start off, this is an alarming fact. You're going to be seeing it over and over again every time you open up your email, every time you look at a professional publication, every time you pick up a paper. Over 50% of U.S. physicians represent some element of burnout. That's frightening. That's almost 2 times the amount of burnout in an age-matched population in the U.S. It's estimated that 80% of this burnout is due to organizational factors. So what does that mean? It's not if we do yoga or eat better or take better care of ourselves and sleep that this is going to go away. It's the environment of where medicine is today and where we practice and the effect on us as providers. Yeah, let's go in. Okay, I just turned it off. Hold on. But while we're waiting to pull up the slide, what is burnout, right? You see it so often. First described in the 1970s by Maslow et al. Burnout is a long-term process. It just doesn't happen from a bad night on call or a crazy clinic. It's the result of a long-term stress reaction characterized by depersonalization, emotional exhaustion, decreased personal achievement, and lack of empathy. Does that resonate with anybody? Has anybody ever seen that in a colleague or themselves? Right? Right? Okay. All right. We know you're out there. You can admit this. Actually, here at Children's National in the 1990s, my own colleague, Alan Fields, actually wanted to look at burnout in critical care medicine physicians. So way back then in the dark ages when I was a trainee, I was like, well, burnout, what are you talking about? That's for old people. Oh, sorry, Alan. Actually, it existed, but no one was paying attention to it. And who knew Alan was such a leader? Okay, so speed forward 20 years from Alan's study, Tate Shenville and all at Mayo initially, he's now at Stanford, started to look at this concept of burnout in all provider groups. Here's a very alarming paper. In 2011, burnout was 45% in clinicians measured. Fast forward 5 years later, up to almost 55%, almost a 10-point difference in burnout. If you look at provider satisfaction, similar statistics over that short period of time. That's amazing. So does anybody remember what was going on in 2011 to 2014? Did anything change in healthcare? Right? I hear a lot of giggles. Affordable Care Act, a lot of regulations, change in how we practice, see more patients, get less reimbursed. Does that sound familiar? Yeah. So I wanted to say that burnout can touch every specialty, but it's particularly prominent in those providers who are on the front line of medicine. Primary care providers, internists, OBGYNs, and of course, you know I had to find a critical care slide where we're #1. I don't necessarily know I want to brag about that statistic, but you know we're sort of high-tech generalists. So I think this is a startling slide, and I certainly welcome you to look for where you might want to be as a subspecialist when you grow up, or a pediatrician, and maybe ask yourselves why these statistics look the way they do. This slide says it all. I have to say, when I looked at this slide, I was so taken back because it's not just about physicians. It's every member of our healthcare team that gets affected by these statistics or these issues. So up in the upper right corner, you see that Stanford study, change in burnout for providers. You see here, can't really see, but we're going to give it to you in a handout. Female physicians are 130 times more likely to commit suicide. 40% of patients, 40% of males. If you look over here, nurses, this is our nursing colleagues. These are the people we practice with every day. 35% higher incidence of emotional exhaustion. You can see that, right? And what's here? 18% more nurses are depressed than their age-matched colleagues. So what does this tell us? This is an indictment on the system where we practice. This is where people who want to go into medicine because they care, because they want to make things better, don't have the energy, don't have themselves, aren't able to do what they set out to do. And when that happens, you feel badly. You don't feel good about yourself. So when does this burnout start? For those of you who are in medical school, it starts in medical school. Sad but true. You actually have to know you matriculate with a higher emotional status. You are good to go when you get in there as first years, but by the time you reach your clinical burden, you're almost as burnt out as we are. And that burnout extends to training, to residency, to fellowship. It's frightening, the statistics. And so people who take care of residency, ACGME, GME committees, they're looking at ways to solve it. And guess what? Work hours didn't fix it. Another indictment of the system where we practice as opposed to the individuals who need more sleep. Here's a nice slide and study done by Stanford looking at the continuum of burnout throughout training. If you look here, if you look at medical students age-matched with the U.S. population of college graduates, they're 49% burnout compared to 35%. Fast forward to residency, 50% burnout versus 31%. And those early faculty, those faculty who come from their training and enter into a new position, whether it be in private practice or in academic medicine, they have a higher burnout scale, 37% versus 29% in their age-matched colleagues in the U.S. population. Frightening statistics. So what are the consequences?
Thank you. Thanks, Christy. So Christy has just done a beautiful job of summarizing how big of a problem burnout is. I mean, this is obviously something that has been increasing in prevalence. It affects many sectors of the healthcare community, and it really starts early and persists. But, you know, the real question is, well, what are the consequences of that? And Christy touched on some of these, but there are very personal consequences of burnout at the level of individual providers. It puts a strain on relationships and sometimes results in broken personal relationships. Alcohol and substance abuse is one of the potential consequences of burnout. Depression, and unfortunately, as Christy mentioned, suicide. And so those results are enough of a moral and ethical imperative for us to do something about this. But even beyond that, there are significant business and institutional reasons to address burnout. Burnout affects so many aspects of safety and quality of the care that we provide to our patients. And so starting first with safety, there have been multiple studies that have shown that as burnout increases, the risk of medical errors significantly increases. Patient satisfaction, so burned out providers obviously are not going to necessarily provide care which patients are optimally satisfied with. Decreased productivity, and so many studies have shown that when providers are burnt out, they're not as productive as they could be otherwise. And in addition, there's an increased risk that they may very soon decrease their clinical load or perhaps leave clinical medicine. And of course, this physician turnover. And so there's a moral imperative for us to address this, but there's also a very real business and professional case to make. So delving into that business case a little bit more deeply, I think this is one of the things that has been most enlightening to me is that there are tangible costs associated with provider burnout. And some of those are direct costs, And so when you're talking about providers decreasing their clinical load or leaving medicine, that results in recruitment and replacement costs that can be exorbitant. So this is one example, taking an institution, let's say, with 500 physicians at the national prevalence of burnout right now, which is 54%. And what that means is that in the typical year, there are going to be 12.5 physicians that turn over as a result of burnout. And that's at a direct cost of over $6.1 million, staggering. And that number doesn't even take into account the indirect costs associated with burnout, which include loss in clinical productivity, increased risk of medical errors, higher malpractice risk, and reduced patient satisfaction, which can affect reputation and referral patterns. And so this is really one of the prime concerns that medical institutions across the country are dealing with, both because of its personal repercussions at the level of the individual provider, but also because it threatens key metrics and business patterns. So we've talked about burnout being an incredibly prevalent problem, increasing prevalent, one that has severe consequences at the level of the individual and at the institution. But what really drives burnout versus engagement? This pictographic was taken from a paper by Shanafelt in the Mayo Clinic Proceedings. And I'll walk through some of the key drivers that are believed to lead either, if they're optimized, to physician or provider engagement, and if they're not, to burnout. So starting first, workflow inefficiencies. And so all of us can attest that there have been tremendous changes within healthcare that have resulted in the electronic health record increasing the time that we spend documenting during patient care. And that has been found to be one of the key drivers in increasing rates of burnout in recent years. Culture shift. And so nationally, there's been a shift in the culture of medicine kind of away from health values and more towards corporate values. And that results in strains on physician engagement as well. At the core of all of this is kind of what brought us into medicine in the first place, that joy, that meaning, that purpose. And as a result of all of these factors, that's being lost by many of us. We're losing touch with what initially motivated us to go into this career. Social isolation, and so more and more, we're not necessarily interacting personally with each other as much as we used to. We're kind of operating in silos, and we don't necessarily see each other and talk as much as we used to, both in professional settings, but also in social settings where we can just relax and learn about each other's families and what's going on in our personal lives. Loss of control, and so as healthcare has become more complex, individual providers have found that they've lost kind of that locus of control over the care that they provide to their patients, and that can contribute to disengagement and burnout. And then obviously high workloads with many of the healthcare changes that Christy has alluded to. And so we looked, as we embarked on this journey to increase physician well-being and provider well-being, we looked at many different frameworks that try to characterize wellness. And the one that resonated the most with us is this one here from Stanford, because it really captures at the center of it professional fulfillment. You know, the reasons that we went into this career in the first place and trying to get back to that. And then it has three domains that kind of contribute to that. The first is the culture of wellness. And so this speaks to the work environment, how it promotes self-care, personal and professional growth, compassion for colleagues, and patients and self. Efficiency of practice, and so this really speaks to the value-added clinical work that we accomplish divided by the time and energy that it takes for us to invest in that. And then finally, personal resilience, and so those things at the individual level that are skills, behaviors, and attitudes that contribute to personal, physical, emotional, spiritual, and social well-being. And so where are we now in terms of provider engagement at Children's National? And this is a slide taken directly from Dr. Newman's Grand Rounds just a few months ago. And that Grand Rounds was really the very spark of our journey. It was incredibly courageous of Dr. Newman to be transparent with where we are right now, because we have to become grounded in the fact that we have work to do in terms of provider engagement. As you can see here, But that was the beginning of the journey, and it really energized us to be that grounded, to know that this is an important problem, an important priority for us to address. And so what is the human impact of burnout? You know, we've talked a lot about quantitatively what was the percentage that we may be burned out at our own institution, what was the percent of engagement or lack of engagement, but it has a very human consequence. And in each of these three domains, the New England Journal recently published a really interesting perspective just a couple months ago that provided kind of firsthand in words what it feels like for providers that are struggling with this. At the level of culture of wellness, I don't feel supported in my career development. In the domain of efficiency of practice, I'm spending days doing the wrong work. Instead of improving efficiency, the EHR seems to be taking time away from patients, adding hours of clerical work. There's too much work after work. I feel like I'm never doing enough or doing it well. And then in this area of personal resilience, at the highest level, we are disconnected from our purpose and have lost touch with the things that give joy and meaning to our work. These were words that individual providers came up with, and Christy and I have started on what we're calling a listening tour through lunches, through meetings with divisions. And I have to say, what we've heard from providers here at Children's National is the themes are so similar to what's being expressed nationally. And so if you're in the audience and you're feeling many of these things yourself, I think the thing that we want you to know is that, one, you're not alone, either nationally or locally here at Children's National. And that's something that we intend to do and roll out even more, is this kind of very active listening to understand and better comprehend what it's like for providers on the ground. So what can be done? I'm going to turn it over to Christy because we've talked a lot about the extent of this problem, the impact of it, the personal impact of it, and so we want to pivot now to what can be done to solve this.
You got the cartoon? Does this sound familiar? Okay. So as part of this New England Journal effort, they have a group called New England Journal Catalyst Group, where they have clinician leaders and hospital administrators, and they ask them all sorts of questions about healthcare. How can we address this issue? And while we are acknowledging, and they acknowledge as well, that a lot of the changes need to happen at the organizational level, because what works at DC Children's may not work at the VA hospital, there are certain things that need to be addressed at quote-unquote a higher level. So what is it that we can do on the national level to address some of the issues with efficiencies of care, documentation, and all those downward pressures that we're feeling as providers in our documentation and medical regulations? Over a third of the providers queried said, we need people to help us lobby. So the AMA is up there, medical societies are up there, the American College of Surgeons are up there trying to lobby for this. And in fact, our own Brian Jacobs, if you've seen his emails recently about documentation for medical student examinations in our EMR, this was a direct effort of providers reaching out to the CMS and saying, hey, this is crazy. Why do we need to do this? So this needs to continue. About a quarter of the providers said, we need a better IT functionality. We need a better EMR. And the key to this, I hear that, did you say amen to that? Yeah, okay, all right, woo. But, I mean, I think this time around, we actually need to put the providers in charge as opposed to the engineers or the administrators. So that's the groundswell as providers that we could actually continue, that if you're going to propose something, run it by us first. We might have some ideas. So I think that's important.
Sure. So you know, what is the path forward? And we've done, I almost feel like we've done another fellowship in wellness, and there's such a wealth of literature that's evolved over the past couple of years, and Christy and I have been immersed in this literature and really tried to glean out for you today what we feel resonates most strongly with us here at Children's National. And this framework for a path forward from the Steps Forward program through the American Medical Association and Stanford really felt right for us. And this provides 9 steps at the organizational level. You know, Christy mentioned before, 80% of burnout is driven by organizational factors, not necessarily factors that are in my individual domain of control. So what are the 9 steps that can help clinicians thrive through organizational change? Well, You'll notice that it's divided again into the Stanford framework, and 6 of these 9 steps reside in the domain of culture of wellness, and that just shows that there are going to have to be significant cultural shifts in medicine and healthcare in order for us to effectively address this problem. So first, engaging senior leadership. And so we're lucky, we're blessed here because we didn't even have to engage senior leadership. Senior leadership, Dr. Newman, engaged all of us. And so he recognized the significance and the depth of this problem and actually charged each of us as providers here at Children's National to try to come up with solutions. Tracking the business case, we talked about this already. Obviously, at the outset, figuring out what is the business case for this, and then following over time how the changes that we execute improve finances. Resourcing a wellness infrastructure, and so this talks to who manages this within an institution or within an organization? How is it resourced? What are the activities that are done to provide kind of that oversight and evaluation? And measuring burnout. So I'm going to turn it back over to Christy because this is a really crucial area for us to actively engage in.
Thank you. So what if I said we're going to advocate that the joy of work gets measured as a quality measure that gets reported in the U.S. News and World Report? Would that be crazy, right? So actually there is a groundswell to make this the 4th aim of care. So in addition to reducing costs, improving patient outcomes, improving access to care, there's actually a clamoring for measuring clinician wellness as a quality indicator for the organization. So we're going to be doing that, and I think it's very nice to know that we have the support to actually move that forward. In the study, again, at the Mayo, does anybody want to work part-time at the Mayo? You know, the grass is always greener, though. Remember that. Okay, so they actually made a commitment to measure provider wellness every year because you can't fix what you don't know. So there's power in numbers and there's power in data. So I think that's very important. What they do with that data, they actually look to see, are there any areas that particularly need some help? Maybe last year's assessment, everything was great, and this year it wasn't. Wow, what changed in that practice group? What changed in that division? So they use it as a pulse check and a way to move forward with quality and improvement in the care they give and the overall wellness of their individuals. More importantly, the CEO and their raises, their evaluations, their whatever, are tied to the quality indicators of the team, of the staff. So linking it to leadership and transmitting it down is fantastic. There are many ways to measure this wellness. We are going to be engaged in the mini-Z, which is sort of like a Maslow, what do I want to call, executive summary. So it's not going to be the full Maslow, but there'll be elements there that will capture the domains in the Maslow summary. And as a result of Mary Odolini's partnership with the AMA Step Forwards program for the residents and trainees, faculty are going to be assessed yearly, and we're going to be benchmarked against national faculty. So that's going to be an opportunity. Stay tuned. Don't really know when that's going to be rolled out, but look for it coming pretty soon.
So step 5, strengthening or what we like to say, empowering local leadership. And so there's actually a wealth of research to show that the leadership skills of supervisors significantly impact burnout and satisfaction. And this is just one example from a study, again, by Shanafelt, who we've referenced many times. For every 1-point increase in leadership score for a physician's immediate supervisor, there's a 3.5% decrease in burnout and an over 9% increase in provider satisfaction. And so at Mayo, based on this data, they decided to regularly assess physician supervisors in 2 ways. One, with metrics, just like Christy was saying, some sort of well-being or wellness score of individual divisions or units. And then there's actually a validated measure, which is shown here, which looks at all of these factors that kind of inform the effectiveness of physician leadership. And so things like, does my physician leader hold career development conversations with me? Does he or she treat me with dignity and respect, inspire me to do my best, empower me to do my job? You know, as we talked about this, this really reminded me of our grand rounds just a week ago from Fran Johnston when she talked about bringing emotional intelligence into how we do each of our jobs as leaders. And that idea of resonant leadership, because it really is bearing in the literature that if physician supervisors more effectively lead, that's one of the key drivers to improve burnout. And number 6, so developing interventions. And so organizations that have been successful at addressing this have had a culture of experimentation. They've had kind of an ease with trying things out that seem to be evidence-based and doing pilots and then collecting data based on those pilots so that then that can inform decisions about whether something should be rolled out more widely. And so that's something else that is important to do in these steps.
And certainly one of the things that we really want to look at is that efficiency of practice. How can we make it easier to get those patients registered, seen, in the room, have their exam done, their anticipatory guidance done, all those sort of things that how do we get a patient from the ED to the ICU to the OR? So how can we improve those efficiencies of practice? What does that mean and what's the impact on us?
So, workflow efficiency, and this is something that's really emerged, is this idea of team-based models. And so there was a pilot program at the University of Colorado. This was in an ambulatory setting, family practice called APEX. And they looked at how we distribute work. Are there certain aspects of medical care that a frontline provider wouldn't necessarily need to do? And they looked at the idea of expanding the role of medical assistants, and so they increased the number. They rigorously trained medical assistants, and then the medical assistants' role included gathering data, reconciling meds, presenting to the provider about why the patient is there, and then staying in the room so that then they would document the visit. Then after the provider left, they would finish documentation and provide patient education and health coaching. In this 6-month trial, there was a dramatic decrease in burnout, just within 6 months from 53% to 13%. And that's something that's very difficult to replicate elsewhere in the literature. Not only did it decrease burnout, but it increased clinical productivity. And so they were able to add 3 extra patients per provider per day, and the wait for new patient appointments significantly decreased. And finally, this was cost neutral. Because of the enhanced clinical productivity, it didn't cost anything in the end to hire the additional medical assistants and to train them. And this quote from the medical director of this program, I thought was just really informative. He said, "The chaos in exam rooms before APEX was akin to texting while driving. The greatest advantage now is that the computer no longer stands between me and my patients. This allows for deeper thinking and deeper connection." So a really profound statement about this pilot.
So the beauty of the EHR is you can do it anywhere. The beauty of the EHR is you can do it anywhere, right? So the fact that you can take your medical records home now and no one knows you're doing it is a crazy secret that we have to try to expose. So basically, for every 2 hours in the EHR, and you have an increase, for every hour you see a patient, you have an increase in your EHR work, and you take that work home, right? So when you take that work home and you see 15 patients in the clinic, no one notices. They say, "That's so great, look at that productivity, it's gone up by 10 patients every time this provider walks in the room." No one sees you at home. No one sees you at home after you put the kids to bed and after you eat dinner that you're still working on your charts, right? So that is really something that we have to be mindful of and really have to make it known to everyone that this is happening. How can we make that, how can we expose the dirty truth, right? Maybe there are quality metrics. Maybe Big Brother signs in and looks to see, wait a minute, she was in her medical record at 10 o'clock at night. She's not supposed to be doing that. Why is she answering my text at 2 a.m.? So there are ways outside of being a big brother in respect of people's privacy to try to monitor this work, to try to see how much time we're actually spending in the medical record when we're not present at work. And I think that that's a challenge for us to figure out how that's going to work and how that's going to work efficiently and effectively for us as a healthcare organization. And just to speak to Heyman's example, when they actually got medical assistance, you see that it's $8 per patient and $80 per day. For us to do work that we may not necessarily be trained for, be the best to do, it's really expensive. It can cost up to $500 extra money just to have me on hold with the pharmacy or the insurance company trying to get approval for that ICU treatment. So again, there are things that we do every day that we're doing that maybe others could help us do better, and that's about us as well, because I don't know about you, but if I have someone telling me they're looking at the labs for my patient and everything was okay, guess who's in the call room looking at labs, looking at the patients, looking to make sure they're okay? So that team-based approach has to grow, and we're going to have to figure out when to let go of some of that control, because it's kind of hard, and when to trust the team and to each do the job that we say we're going to do within the team. And so finally, we want to address the personal resilience. What are those strategies that we can teach, learn, develop, emulate, model that will help us deal with the road ahead? So this is one of my favorite examples. This is, again, out of Stanford. They did a wellness survey, and they actually got qualitative comments, and one of the comments was from female faculty in particular: I don't feel supported in the work I do. I don't feel I have direction. I'm not getting the development that I need. And so people said, well, let's do a pilot study. Let's ask for some funding, and let's do this. Let's try to make the work we do every day that doesn't necessarily get counted as protected, teaching medical students, giving lectures, participating on committees. And we give people credit for that. What they do with that credit, they'll have some choices. What they do for that credit, we're hoping to help them have that number go down as far as lack of support and go up as far as happiness and productivity. And what they found, that they offered this to everyone, and some things that were offered: meal prep to the house, daycare, cleaning. Wow, wouldn't that be great? Okay, but I'm really thinking about my academic career, so statistical help with my project, somebody to help me write a grant, somebody to help me get this paper out there where it belongs. So all these services were offered, not just on one line. It was open to all physicians and all scientists within the Stanford medicine faculty. Women used the services disproportionately more than men, and at the end of that, those physician comments, and especially in the female faculty, went up. So this is a perfect example of, as you throw some seed money in, you recognize people's work in other domains in the typical domains that get funded time, and you'll have a happier, more productive group. I forgot to mention that as a result of this effort, there were more grants submitted and more papers published from the faculty during this pilot study.
So how else can we enhance resilience? So this idea of connection, we talked about social isolation. So at Mayo, they created a program called Compass, which allowed small groups of physicians to meet for dinner every 2 weeks at a cost covered by Mayo. And they kind of prompted the discussion in the beginning by asking them to discuss topics related to the virtues and challenges of physicianhood. A clinical trial of this showed a significant improvement in meaning and burnout, and that was then rolled out to all faculty. And when it was rolled out, within the span of less than a week, hundreds of faculty had signed up to join these small group dinners. So another example of connection. And then finally, personal resilience. And so in 2016, there was a meta-analysis of all of the interventions that had been tested, both randomized trials and cohort studies, to reduce clinician burnout. And there were two take-home points. One was that the most effective strategies combined organizational level interventions with personal level interventions. And so if you just say, do something personally, it's not going to have as much impact as if you couple that with organizational change. Among the personal targeted interventions, the ones that were found to be most effective included some aspect of meditation and stress management training. And meditation is something that has been gaining increasing attention because there's a growing body of evidence to show that it works. At a physiologic level, there are improvements that occur as a result of regular meditation. And just to share kind of a personal story with myself, I myself found myself burned out just a few years ago. And that's, you know, statistically 1 out of 2 of us had to be burned out at some point, right? So that was me. Even though allergy and immunology was at the bottom, I found myself burnt out. So in any case, now looking back in retrospect, I recognize that the one singular intervention that made the greatest difference, the transformative difference, and sustained it for me was daily meditation. Because we're embarking on changes at the organizational level that are not easy and also that take time. And what will effectively allow each of us to do that is starting from the point of a stress-free, calm mind. And that's what meditation does. And so we're in a few weeks, we're in for a really remarkable, almost once-in-a-lifetime opportunity here at Children's National. So just in a few short weeks, Sri Ravi Shankar, who's the founder of The Art of Living, he's a global humanitarian, spiritual leader, peace ambassador. He's coming right here to this auditorium on Friday, April 20th from 9:30 to 10:30. And he's going to be conducting a conversation about healing from within. Because if we really are embarking on trying to more optimally heal our patients, their families, and our communities, it starts with us. And that will allow us to then execute the changes at the organizational level that need to accompany that. And so I hope that everyone puts this on their calendars and comes for this very special session.
Timing-wise, that's the end of Research Week. So it'll be a fantastic closure to a very busy and productive week. So a little brag time here now. So the Provider Wellness Committee, as you saw, we have tons of members from all over the organization, but still there are plenty of seats at the table if you care to join us. We want to thank Karen Smith for her leadership on the medical staff, and Denise Cora-Bramble, who's our executive leader. But I'd be loath to forget that this actually started from an anesthesiologist's recognition that we don't have wellness here at Children's, or a way for us to gather that. And Therese Roberts from anesthesia actually put through all the paperwork and all the mechanisms to make this actually a medical staff committee. So I want to thank her publicly for all her hard work. We have lots to do. We have engaged some medical staff on the ground. Come to a lunch and learn. We'll always have something to talk about, albeit for 15 minutes with lots of good food. But what we've heard from those events are they're great. Have more. How about a physician lounge? Okay, that's on record. Okay, so one of the great efforts is that we recognize that wellness is not just about doctors and clinicians. It goes across all groups. So currently we have a good relationship with our GME Wellness Committee, and we don't need to recreate the wheel. We have our nursing colleagues that we're working with, and hope to have a lot more joint efforts moving forward. And we're keeping Kurt and his leadership, or Dr. Newman and his leadership team up to date, and we are so appreciative of all the support. And yeah, this is the first ever Doctors Week, so, yay to you all. But recognize that we have a lot to do, so if there are ideas or thoughts that you might want to do throughout the year as well as next year for Doctors Week, please let us know.
And so with this work that we've started, that we've embarked on, what are some of the early insights? Well, I think the first one that has really clarified itself over and over again to us is that leadership, Dr. Newman, executive leadership, they're invested and they really care about this issue. They recognize that this is impacting us as individuals and our patients as a result. Similar themes are emerging across very diverse medical staff, and those themes are matching up with what we've observed nationally. The medical staff is a powerful voice for change. The Wellness Committee is a dynamic, enthusiastic group with lots of energy, lots of ideas, and they've already been able to impact change within the organization. And then finally, as we've said over and over again, organization-wide strategies are needed in addition to the individual targeted strategies.
So as I mentioned, we need you, but so if your division hasn't had a listening tour, please reach out to Hammond and myself and let us know that you might want us to come by and just have a conversation with your faculty. We'd love to do that. It takes about an hour. Network with your professional societies. Just at the recent Society of Critical Care Medicine, wellness was a hot topic, so I'm sure that's happening in all our professional subgroup societies. Just here in town, the National Academy of Medicine, formerly known as the IOM, has a huge collaborative initiative that they've been involved in, and there's a day-long conference right here in DC on May 2nd, and I encourage you all to go to the website and register. It's free. There's an art show. It looks like it's going to be great, and it'll be an opportunity. It's the 3rd Congress. Who knew? Then think about what you can do locally. Don't wait for us to come from on high with these solutions and fixes. Look at your day-to-day workflow. Look at how you learn. Look at how you whatever is in your day that might be a pain point, and look for that opportunity for improvement. Propose a pilot, come to us, go to your boss, whatever that looks like, but always be encouraged that if there's an idea for improvement, there's an ear to listen. The climate is right, so please take a look and then put those recommendations moving forward.
So we entitled this talk based on our recently developed core values, and we wanted to end with those because they really align so well with this work that we're trying to do. First, compassion. And so we've talked over and over again that really in order to optimally care for others, we have to first care for ourselves. And once we've cared for ourselves, we also then need to show compassion for each other, watching out for distress in others, reaching out, active listening, and really, as Fran Johnston talked about, resonant leadership, using those emotional intelligence tools to find out how someone's day is going and really asking, are you okay? What's going on? So compassion.
Commitment. So know that there's an organizational commitment right now for provider well-being, and keep asking for those metrics. When we do a survey, let's get the results. Let's see what opportunities we have for improvement, and always be mindful that we can improve. And then yourself. Don't suffer in silence. Don't go home and drink a whole bottle of wine. Don't eat a whole chocolate cake, which I might do. So don't suffer in silence. Speak out. If you see something that's not quite right, speak out to the appropriate, go to your supervisor, go to your direct boss, propose new ideas. Don't just say it's always going to be like this, there's nothing to do. Because guess what? All those papers we showed you, that's evidence that some change can happen, and positive change will happen when we're all committed to make it happen. And as we say, be the change we hope to be.
And then finally, connection. So really creating the community that we're all yearning for with colleagues so that we can combat social isolation and promote sharing of ideas in person, one-on-one. Connecting with our patients through enhancements in workflow and efficiency. So as the trial at University of Colorado said, feeling like you can actually connect with your patients because the EMR isn't necessarily in the way. And then finally, and most importantly, reconnecting to our professional joy, purpose, and meaning. That's what this work is all about. That's what we're all aiming for, and we really are excited as a group to embark on this journey, and we hope that you will join us. One last announcement, if any of you have missed the meditation activities so far this week, there's a very special opportunity right after Grand Rounds right here for about 20 minutes. And so if you can take additional time for yourself, compassion for yourself, it'll be a really great session to learn a little bit more about meditation. But we're just so excited about the work ahead, and I couldn't ask for a better partner in this work.
Likewise, we're doing great.
And we are happy to take questions from the group.
Before we take questions, just want to challenge you all, when you leave here, write down 3 reasons why you went into healthcare. Why'd you go into nursing? Why'd you go into medicine? Just take that time and space for yourself to reconnect to your original purpose. Okay, questions. Sorry. Hello.
So I was going to start by, I don't know if I'm congratulating you on the completion of your wellness fellowship or on the start of your wellness fellowship, whatever it is. But seriously, thank you for all your effort. And although you're from the hospital, I think the stuff going on this week has been great. And I look forward to us coming. So I had a question and a comment. My question is, and I'm going to be a bit cynical for a moment. This all sounds I'm actually not this is obviously amazing and long overdue. But there's probably not a single person sitting in this room who I'm going to say is over the age of, let's say, 35, who hasn't at some point, if not frequently, bemoaned the era of duty hours and all these cliche things we say, and how people, you know, the kids these days don't work as hard. I'm not saying I believe that. However, there is certainly a challenge between, and as someone who has education as a large part of their career, role modeling the kind of dedication to our craft, whether that's reading, you know, doing research, whatever it is, to our patients, and the time that this takes, right? We do not have 9-to-5 jobs, and none of this says we do, but I think there's an important distinction that needs to be made. Medicine is hard work, and it's serious business, and it needs to be treated that way. So what's the balance between wellness and the kind of dedication, and I'll say intensity, that all of our careers require? So that's a question. And then the one comment, which is really a challenge for our organization, is that, and I'm going to push you, Christy, I don't mean to pick on you, but on your comment about the EMR, and I'm not defending the EMR because I don't want anything thrown at me. But what I will say is they did try to engage providers. And there were a lot of people who worked very hard on this. And from most of the hospital, there was crickets. And so I'm not criticizing our staff, but what I am saying is we are not offering the right incentives. Right, so if you look at our goals and objectives, we fill out every June, July, whatever it is. If you bring in an NIH grant, you know, you've met your threshold pretty easily. But if you've spent 80 hours doing committee work for the hospital, peer review, education, those are fractions of a point. And so I think we have an engagement problem. And the first thing I would say is, what are we doing as an organization to prioritize our incentives? If we need a better EMR and we need more clinician input, what are we going to do to make it worth those people's time to do it?
Oh, boy. Okay. So, Lowell, I appreciate you directing that question. None of this is easy, and none of the answers are out there yet. So we're just hearing the tip of the problem from our faculty, and this is certainly something that we hope to know more about. So that perhaps is one of the proposals. Reevaluate the goals and objectives, ranking for those in kind of like the Stanford model, right? I'm on 10 committees, I get to, get my dry cleaning done, or whatever that looks like. So that's to be in the future. As far as the education and the modeling and the time, I'll just speak to my experience.
That one's hard because I feel strongly on both sides of it, right? Duty hours are smart. Working 160 hours in a week is not smart, right? So.
Yeah. I think we have to, as I'm only 39, but as only 39, I think we have to, we sort of have to model that behavior. And that's where the challenge is for the faculty, to not look burnt out, to get some help if you're having challenges, to reinvent that joy. That's on us. Right? And so maybe our colleagues who are younger aren't going to be working the crazy hours we did, but doesn't mean that they shouldn't be as engaged and as passionate. And quite frankly, we might learn from them, right? Because they're not yet to the point where I might be in my career as far as cynicism or doubt. Yeah.
And time is an interesting phenomenon because I've found myself, there's this aspect of Sri calls it inner peace and outer dynamism. And so we oftentimes bemoan, I don't have enough time. But once your head is straight and your mind is clear and stress-free, it's amazing how dynamic we can become with the limited amount of time that we have. And also, we can then select what is important and what isn't important. And I think that for many of us, is the challenge. It's not so much the hours, but it's really coming to it with that perspective, with that clear perspective of what do I do, what's most important, and how do I effectively do it dynamically. But I agree. I mean, we need to incentivize this work of engagement because it's not easy work. It takes time. It takes energy. But the energy is there. I mean, that's one thing that has been so evident to us. The ideas, the energy, the enthusiasm, it is there all throughout this institution. And it's just a matter of unleashing it and identifying what are the mechanisms, the incentives that will allow that to happen.
Well, first of all, I'd like to thank you and everyone else who's been involved in this process for doing this. Kurt is actually giving grand rounds at Boston Children's today, otherwise he'd be here with us because he's really very supportive of this. But my question is, when I think of medicine with a big M, there are at least 3 different types of medicine. There's those who are in private practice, there are those who are in large clinical institutions like Kaiser, and then there are academic medical centers like us. And I would suspect that there would be both qualitative and quantitative differences in the issue of burnout and the causes among those 3. I wondered whether that was something that you could speak to.
Yeah, it's something, so at our national academy level, the Allergy Academy, we've begun looking at this, and it's interesting because the drivers of burnout do differ based on the role, which of those 3 roles we occupy. For researchers, for example, a lot of burnout is driven by kind of disenchantment with the grant process, you know, getting discouraged when grants get rejected or getting discouraged when a paper gets rejected that they work so hard on. And so definitely the drivers of burnout differ. Some of the strategies, however, overlap. And so at the organizational level, whether one is at an academic medical center or a private practice or a clinical enterprise, the strategies to make clinic function better help everyone. But in terms of academicians, definitely there are some distinctive drivers for that group.
Wow, I waited 25 years for this. I congratulate you and the administration. We're to the table late, but you're up and running. I have 2 comments. Number one, this is heavily weighted towards physicians, which is fine, but nurses get burnt out also. Matter of fact, the vehicle I used was a nursing vehicle and stuff like that. So remember that. It's a good start, but they need to have coverage as this therapist and everybody else. And 2 is there was a time when you can go into medicine there and you do that forever. You can be a clinician forever and stuff like that. Those days are gone, and you can't predict 20 years from now what it's going to be like. Because it's not the clinical care. My study showed it. Every other study showed it. It's all the garbage that goes around it. This is getting worse and worse. So my suggestion is for those people who have 3-year fellowships, or for even potentially for incoming residents, right after you say hello on July 1, the next question next question you should ask is, I want you to imagine 20 years from now, okay, that you in fact cannot mitigate burnout, and you have 1 kid in college and 2 on the way. What are the skill sets that you have that you may be able to use for employment? Okay, and my point being is that when my burnout study came in '95, the next several years, several of the pediatric ICU fellows, 3-year fellowships there, went to GW there and got their MPHs. So whether it's an MPH or an MBA or a BLT, it's up to you. The point is, it's a lot easier to do it during that training period than waiting until you're 50, you're burnt out, and say, okay, now I need to get other credentials there. So that should be a consideration.
Thank you, Al.
Thank you.